Good evening. Myself is Dr. Harish Malapura Maheshwarappa. So I am working as consultant in the Department of Critical Care Medicine, Narayana Hrudayalaya, Bangalore. So now I am planning to come up with series of lectures on acute respiratory distress syndrome. So it's a very important aspect in critically ill patients in medical intensive care unit or maybe a surgical intensive care unit. So if you understand, so in the last couple of decades, lots of things has been happened in the diagnosis, management, and in the outcome of so-called ARDS. But still, in a good tertiary or quaternary care center, the mortality, death rate remains in and around 40 to 50%. So still, lots of things are in the pipeline. So in this my first lecture, I just want to get some idea what are the newer things which are happening in this current year, that is 2019. So maybe it's in relation to like diagnosing, pathophysiology, or it may be a basic ventilator strategy, or some adjuvant therapies, or some rescue therapies in ARDS. So I call it as acute respiratory distress syndrome 2019 update. So if you see, so Ashberg and Petty, these are the two who coined the term ARDS, that is acute respiratory distress syndrome in adults, in 1967. Before that, there were lots of confusing terminologies. So it was called as acute respiratory failure, capillary leak syndrome, shock lung, traumatic wet lung, adult hyaline membrane disease. So basic idea, you know that ARDS is a non-cardiogenic pulmonary edema. So fairly heart is not the culprit in a patient whom we tag them as an ARDS. So, but if you see the previous terminologies, so they tried to coin each terminology just based on the pathophysiology of this ARDS. But the first official definition we got it from AECC 1994, that is American European Consensus Conference. So I told it's a non-cardiogenic pulmonary edema. What criteria they used to define ARDS is pulmonary artery wedge pressure. So depending upon the PaO2 by FiO2, they classified it as acute lung injury and ARDS. This already we know. So someone who is having less than 300 PF ratio, they call them as an acute lung injury patient. Someone who is having less than 200 PF ratio, they call them as an ARDS. But common criteria they kept was bilateral infiltrates and pulmonary artery occlusion pressure, or pulmonary artery wedge pressure, which is left atrial pressure, or left ventricular end diastolic pressure, so which they considered if it is less than 18 millimeters of mercury, so they excluded it is not cardiogenic pulmonary edema. So as the decade evolved, okay, lots of deficits in that AECC definition. In 2012 we got something called Berlin definition, because they defined acute onset of infiltrates, but nowhere like we were understand. So how acute, what is the exact meaning of acute? So in Berlin definition they given a clear-cut criteria. So from the onset of insult to the onset of infiltrates, so up to 7 days, okay, so that is the acute. So then like imaging wise, okay, the infiltrate should not be explained by collapse, effusion or nodule, that they included in Berlin definition. So origin of edema, so again it's not whole and soul explained by the cardiac origin or fluid overload. Here one thing what we can use is like we can use echocardiography to exclude, okay, heart is not the culprit for the pulmonary edema. So major development in this Berlin definition which came out in 2012 was they included the PEEP criteria. So we know that positive end expiratory pressure is having an impact on the oxygenation. So they used a PEEP or CPAP criteria of 5. So they classified it into mild, moderate, severe. Okay, someone who is having a PF ratio in between 200 to 300, they classify it as mild. Moderate, that is between 100 to 200. Severe if it is less than 100 millimeters of mercury. So again, why we need to understand to classify mild, moderate, severe? Because see, we know that ARDS is the same spectrum with a different severity with different mortality. If you see mortality, so in patients who are having moderate severity is somewhere around, so mortality is going to be 13%. So it means it's around 27%. If they have a mortality increases where there is an increase in severity also. So it means like if they move from mild to moderate to severe, so there is an increase in mortality. In the same time, there is an increase in ventilator days also. So more number of ventilator days, more the duration they are going to stay in ICU. So that's why we need to understand which severity we are dealing with the ARDS. So most common presentation of ARDS is moderate. So near about 50% of patients are going to present with moderate severity of the ARDS. Again, suppose where we have working in some areas where we don't have the resource, so resource limited areas, or want to treat the patients like pediatric and neonates where we are not able to get the arterial blood gas analysis immediately. So we have some criteria. This is a newer development which we came across in 2018. There is some criteria called Kigali definition of ARDS. Okay, what they have done, they used oxygen saturation, that is SpO2 by FiO2 instead of PaO2 by FiO2 in a patient whom we are not able to get the ABG. So maybe in a community health center. Okay, so they had a good correlation. If SpO2 by FiO2 is less than 315, so it is going to correlate with the PF ratio of less than 300. So they have done a validation study, shows a good sensitivity but moderate specificity, means it's having a good screening test value, it's having a good negative predictive value. So if it comes positive, okay, so then there might be ARDS or there might not be ARDS, but if it comes negative, safely we can rule out patient is not having a ARDS. So this is the validation study. The next $1 million question is, so we don't know many times whether we are dealing with the ARDS or it's a just interstitial viral pneumonia. Okay, so lots of confusion. For a pulmonologist, it may be just a viral pneumonia. For me, it may be just an ARDS. Okay, so how we can rule out or ruling, so viral pneumonia or maybe any pneumonia with that of the ARDS. Okay, there is one more criteria which has been recently developed, that is called RAIL criteria, that is Radiographic Assessment of Lung Edema. So simply what they have done, they have taken into consideration of like consolidation, number of quadrant involved in the chest X-ray along with that of the density of consolidation. So they multiplied consolidation area into that of the density. They given some like score for that, heavy, moderate and dense density. So 1, 2, 3 the scoring. So depending upon the consolidation area involved, like less than 25%, 25 to 50%, 50 to 75%, more than 75%. They given a mark 0, 1, 2, 3, 4 and they multiplied. So maximum score was 45. Okay, so what they found, so whenever there is an increase in so-called RAIL criteria, so there is increase in severity of the ARDS with a poor PF ratio, along with that survival outcome was also very bad if there is an increase in RAIL criteria. So on the other hand, what interesting thing they came up was, those patients who are going to have the lesser RAIL criteria, their cumulative fluid balance was less. So conservative fluid management significantly decreased the RAIL score over the 3 days compared to liberal fluid management. This is something new. So to understand, okay, but we need more and more validation of this score in different category of patients, like maybe direct lung injury, indirect lung injury, so ARDS in elderly, pediatric, immunocompromised and all. But this looks like some sort of hope in diagnosing, differentiating pneumonia versus that of the ARDS. Again, what developments happened in terms of pathophysiology? We know that so ARDS spreads over a period of like a week to 1.5 months in terms of pathophysiology. We have something called exudative phase, proliferative phase, fibrotic phase. So on a gross, so each phase is going to last about 1 week to 10 days, but there might be lots of overlap is going to happen. So first, if you consider exudative phase, what is going to happen? So we know that lung is an innocent bystander when it comes to ARDS. Okay, so something happened, patient is a diabetic, is going to have diabetic food, so skin soft tissue infection is going to have a sepsis, so lung is going to suffer with ARDS. Okay, patient is having a pancreatitis, is going to have the ARDS. So what is going to happen in ARDS is, so there will be some sort of infiltrates, so there will be activation of neutrophils, okay, release of cytokines, they are going to damage to the alveolar capillary membrane, so there is an increase in permeability, increase in interstitial edema, so the lung compliance will decrease, so their work of breathing is going to be increased as a compensatory mechanism, they suffer gas exchange deficiency, hypoxemia and hypercapnia. Okay, but the problem is, do you think all the ARDS patients so will respond to the therapy in a same way? It's not. Okay, sometimes what happens, some patients will come out in a good way maybe at the end of 1 week or maybe at the end of 2 weeks. Some patient will stuck up and they land up with so-called fibrotic phase. So they are going to have a functional incapacity. They might depend on the long-term home oxygen therapy. Why it is so? There is something called endotypes or phenotypes of ARDS. Okay, if you see the study which conducted in 2018, so what they have done, so they classified ARDS into hyperinflammatory and day 1 to hypoinflammatory depending upon some biomarkers like interleukin 6, interferon gamma, angiopoietin 1 and 2 and plasminogen activator inhibitor 1. So those who are having a high level, so they require high PEEP, improve the outcome in those hyperinflammatory patients. So liberal fluid management worsened the mortality. So they require higher vasopressor use, lower serum bicarbonate in those patients. So higher prevalence of secondary sepsis in hyperinflammatory patients with ARDS and day 0. So more mortality, more ventilator requirement. So more organ damage occurred in patients who had a hyperinflammatory response. On the other hand, so conservative fluid management strategy was harmful in hypoinflammatory group. Okay, definitely we need so negative fluid balance or U balance in a patient with having hyperinflammatory, but that may not apply in a patient who is having hypoinflammatory at the day 0. This is something interesting, which is some new concept in ARDS which we can consider in 2019. Again, coming to pathophysiology, we know that there is something called direct versus indirect lung injury. Okay, so most common cause for ARDS is indirect cause, that is the sepsis. Okay, indirect cause is the most common, but direct cause, pneumonia is the most common among the direct cause. Why we have to understand the difference between direct versus indirect? There are lots of targets, therapeutic targets which are happening. So in terms of like origin of this ARDS. Okay, so lots of things are happening. So if it is an indirect, so which patient done well? Okay, if the infiltrates are originated because of the indirect, they responded to the prone ventilation in a good way. They responded to the recruitment in a good way. So we have to understand this is some new concept which is evolving. Lots of therapeutic targets are going to happen in terms of the pathophysiology of ARDS. When it comes to management, what are the new things happening in 2019? We know that so there is something called lung protective ventilation, which is the main basic management strategy. Along with that, we have to identify and treat the underlying cause. So when it comes to lung protective ventilation, so low tidal volume and high PEEP, application of PEEP. This is the main strategy. Along with that, we have some supportive therapy. Okay, give them the negative fluid balance, vasoactive agent, inotropic agents, consider good nutrition, physiotherapy, so DVT prophylaxis, position change, mobilization, sedation holidays. Okay, all these are the supportive care. But when it comes to lung protective strategy, so low volume ventilation is the main thing which we do in lung protective ventilation. So why we need to give the low tidal volume? If you understand, so the ARDS distribution is inhomogeneous. Okay, most of the infiltrates are going to happen in the dorsum of the lung. So ventral aspect, little lung volume is amenable for the ventilation. That volume of the lung is almost as equivalent to that of the lung volume of a baby. So this is the concept of baby lung. Okay, we have to ventilate the patient with the lowest possible tidal volume so that the available volume of the lung is going to be equivalent to that of the baby lung. So there were lots of trials happened. Okay, so in low versus high tidal volume, so the major trial which showed some sort of landmark benefit, mortality benefit, that is called ARMA trial. They compared so 6 versus that of the 12 ml per kg. So definitely survival was better in low tidal volume group of the patient. So again, this is the ARMA trial. So there was a decrease in 9% absolute reduction of mortality when we keep the P plateau less than 30 centimeter along with giving a tidal volume of 6 ml per kg. So other than the mortality, they got a benefit of organ failure free days, which was much better in 6 ml per kg as compared to 12 ml per kg. But there is a concept, we know that there is something called ventilator induced lung injury. We know that, so when you give a more and more tidal volume, which leads to barotrauma, which may happen in terms of like pneumothorax, pneumomediastinum or subcutaneous emphysema, volume trauma, or if you have not given adequate PEEP, so then at the end of expiration alveoli may get collapse, and during inspiration it may expand. So this shear stress which is going to create the trauma injury, we call it as atelectotrauma. So basically all these three trauma, so which caused because of the ventilator, leads to something called biotrauma, which leads to release of inflammatory mediators. Again, it will act on the alveolar capillary membrane, increases the permeability, which leads to the picture which is same as that of ARDS. Okay, so basically we have to avoid ventilator induced lung injury when we are ventilating the patient with ARDS. Suppose I told there is something called atelectotrauma. Okay, I told give them the adequate PEEP, but on the other hand, some like theoretical rationale is happening. Okay, high PEEP is going to be bad, because if you give more and more PEEP, which is going to cause collapse of adjacent healthy alveoli, PEEP is going to have a negative effect on the hemodynamic like findings also, which is going to decrease the venous return, decrease in the cardiac output. So end organ hypoperfusion may happen. PEEP is going to have some neurohumoral like effects also. So with all these findings, so we have to keep PEEP minimal. So there is some concept evolving that is called permissive atelectasis. Okay, no need to give them the high PEEP to prevent the atelectasis, accept a bit of basic atelectasis. Okay, how we have to achieve this one? A minimal PEEP to allow permissive hypoxemia. Okay, so our target in ARDS oxygenation criteria is more than 88%. Okay, we don't want initially more than that. So give the PEEP just to maintain the oxygen saturation, just SpO2 more than 88%. Give that low tidal volume to ventilate the aerated lung alone. Okay, we are not bothered about already destroyed lung. And respiratory rate keep to accept a permissive hypercapnia. Okay, so these three like criteria together we call it as a permissive atelectasis. We have to see more and more paper maybe in the coming decade. This is something which happened newly in the last 1 to 2 years, that we call together as permissive atelectasis to prevent the adverse effects of high PEEP. Again, some more concept has been evolved in last couple of years. So that is called driving pressure. I told there is something called baby lung concept. Okay, so we are giving a low tidal volume to ventilate functional lung, which is as equivalent to that of the volume of baby lung. So, but the question is, are we 100% sure that remaining lung is compliant or not? Okay, if we have given a tidal volume, even though it is low tidal volume, but if the lung is not compliant, okay, so if the respiratory system compliance is not good, that is of the remaining lung, so then we are going to do the harm. So how we can like calculate this compliance of the respiratory system? So that is by something called driving pressure or delta P. Okay, so if you subtract PEEP what we are keeping from that of the PEEP plateau, that which we are going to get by end inspiratory pause, that we call it as the driving pressure. Okay, so basic idea, we are able to understand the respiratory system compliance of the remaining aerated lung, that is the baby lung. So basically a good like evidence, so driving pressure and survival in acute respiratory distress syndrome. So if you keep the driving pressure somewhere less than 14, so survival is good as compared to the driving pressure cutoff of more than 14. So basically it is a P plateau minus P. So on the other hand, so initially we thought that so tidal volume is the one which predicts the mortality, but really if you compare driving pressure versus tidal volume, driving pressure is the one which tells about the barotrauma and that of the other adverse outcome. So this is new concept again which we can adapt in this year, so in practicing management of the ARDS. So one more indices, there is something called stress index. Simply, so how you can evaluate the stress index is, you just go to pressure versus time scalar in like ventilator. If the stress index is less than 1, if the curvature is convex, so then patients are going to have more and more like atelectotrauma, more collapse at the end of expiration and more distension at the end of expiration. So usually which leads to shear stress, more and more release of the biomarker, which leads to some sort of biotrauma. Okay, so atelectotrauma, if stress index is less than 1, how we can identify if the curvature is convex. Okay, if it is straight line, stress index is going to equal to that of 1, so then we are adequately ventilating without any barotrauma or atelectotrauma or biotrauma. If it is concave, So which means stress index is more than 1. So then we are creating more and more of like value trauma. So which is going to over distend the alveoli. So which leads to value trauma. Basically we have to ventilate the stress index which is equal to 1. Our like pressure versus scalar should looks like a straight line. So again, lots of evidence in this stress index, but it's a bit difficult to practically apply at the ventilator. We need a fine tuning, fine knowledge on the scalars before we jump on concluding, okay, what is the stress index of particular patient. Again, what associated strategies like which developed in the last couple of years, which showed some sort of benefit. One is the position change, other is the neuromuscular blocking agents. Okay, so prone position. So now it is not called as an adjuvant or advanced therapy. It is the basic standard of therapy in our practice also. So in a season where we are going to get lots of H1N1 pneumonia patients, we are going to prone the patients. So like left to right without any restriction kind of this one. There are lots of good theoretical benefit. I told in ARDS the distribution of like opacities is going to be in the dorsum. So which when you put the patient on prone ventilation, it first relieves the cardiac and that of the abdominal compression on the lung. So which improve the ventilation. Perfusion remains fairly the same. Because of redistribution of ventilation, overall benefit in improvement of ventilation perfusion ratio, which also facilitates the drainage of secretions, so which also augment the like benefits of recruitment maneuver also. So basically, so prone ventilation is having a fantastic theoretical rationale. But the problem was initial studies they were not able to show any benefit. So Gettinoni, Guerin, Mansubi, these are the 3 persons who done extensive studies in prone ventilation. So initial studies they were not able to show the benefit because the inadequacy of the duration of proning or inadequacy of the power of the studies. Okay, they included less number of patients, that's why they were not able to show any mortality benefit. This is a landmark trial which published in 2013, that is Proseva trial. So good randomized control trial, multi-center, prospective, near about 466 patients with ARDS they included. They given on an average prone session of 17 plus or minus 3 hours. So fantastically which showed mortality benefit. If you see, mortality in prone group was significantly like less as compared to that of the supine patient. They proned the patient somewhere, those who are going to have a PF ratio of less than 150 within 48 hours of diagnosing of ARDS with good clinical outcome. So what happened in terms of neuromuscular blockade? This is the accuracy trial. So near about 340 patients with a PF ratio of less than 150 they included to give cisatracurium infusion with neuromuscular monitoring. So what benefit? Definitely which showed us some decrease in mortality if you use muscle relaxant. The benefit is, so you avoid the desynchrony, so you can give a bit of PEEP. Okay, when you are giving a low tidal volume, so which doesn't allow the patient to trigger, double triggering the ventilator. These are the theoretical benefit. At the same time which showed a good evidence in terms of outcome also. But we have a recent trial, last year only we got something called Rose Petal trial. So again they try to use the neuromuscular blocking agent, but which doesn't show any mortality benefit, neither benefit nor harmful if you use the muscle relaxant in the initial phase of ARDS. Again we have to wait for some more good conducted studies in terms of neuromuscular blocking agents. So next, coming to recruitment maneuver, can we use the recruitment maneuver in all the patients? So answer is no, because what commonly we use it, okay, give CPAP of 40 centimeter of water for 40 seconds, intermittent size, intermittent increase in PEEP, increase in the ventilator pressure to a plateau pressure of 50 centimeter of water for 1 to 2 minutes may not always apply in all the patients. Basically recruitment maneuver is, so expand the alveoli, fill the alveoli. So the same expansion can be maintained with the application of PEEP. So distend the alveoli with recruitment. But the problem is only those patients who are going to have homogeneous opacities, those with a PF ratio which fits into moderate to severe ARDS, those patients who are having a ARDS because of indirect or extra pulmonary or secondary ARDS, in those patients this recruitment maneuver benefited. So we can't give the recruitment maneuver for all the patients like heterogeneous opacity, or if the PF ratio is like more than 150. You have to understand. So all that looks recruitable is not recruitable. So again, what other newer concept we can like think in the current era? I told we have to give the low tidal volume ventilation. On the other hand, what we are doing, we are accepting the permissive hypercapnia because we are not able to wash out the carbon dioxide. Suppose if the like tidal volume is the one which creates the problem, can we come down on the tidal volume maybe less than 6 ml up to like 2 ml per kg, allow the CO2 to build up, remove the CO2 with something called extracorporeal CO2 removal, that is called low flow ECMO. So if you are removing the carbon dioxide which generated because of the lowest tidal volume, so then we call it as extracorporeal CO2 removal. A good evidence is happening, that is the trial, it is called as supernova trial, okay, that is called ultra lung protective strategy. What we know currently, that is the lung protective strategy, come down on the tidal volume up to 2 ml per kg, allow the CO2 to build up, take out that CO2 with something called extracorporeal CO2 removal, that is called A lung or nova lung, or that is called low flow ECMO. So we have to wait for a good evidence before we conclude, okay, we have this facility at the bedside. Again, is there any role of NIV? Why I put this slide? Okay, we know that NIV is bad in ARDS, which gives a false hope. No control over the tidal volume. Tidal volume is the key player in ventilation. Okay, we have to give low tidal volume. But when you put the patient on NIV, suppose if the patient is having a high respiratory drive, he can generate the tidal volume more than 8 to 10 ml per kg. Again, if you increase the pressure support to decrease the work of breathing, again which can create a more and more increase in tidal volume. So we can't give much PEEP on NIV, so there is an alveoli collapse at the end of expiration. So negative pressure swings plus positive pressure support may allow transmural pressure, that is the P plateau pressure, which may kick off more than 30 centimeter of water. This is our understanding. So why NIV is bad in ARDS. So but there is some revisited studies has happened in non-invasive ventilation. So they used NIV helmet instead of face mask. So this is 83 patient data which showed face mask arm had mortality about 56% at the 90 days as compared to 35% in helmet arm. Because if you put the patient on helmet, we can give bit adequate PEEP maybe up to 8 to 10 kind of this one. The tolerability of the PEEP in helmet patient is good as compared to face mask patient. But before we jump on generalizing this study, we have to wait for more and more well conducted like RCTs on using this NIV helmet as compared to face mask. Definitely, so helmet is having one edge above the face mask when it comes to the application of PEEP. So again, some more newer modalities of like ventilation, can we use something called adaptive support ventilation? So background is it's a closed loop mode, can minimize the work of breathing and thus potentially improve the outcomes in ARDS. So this is a small study, near about 50 patients they included. So the mortality in volume controlled ventilation was 36% versus adaptive support ventilation about 34.7%. Ease of use of mechanical ventilation, daily stoppage of midazolam and vecuronium dosage, and number of ABGs which we performed was less in adaptive support ventilation as compared to regular volume control ventilation. It's a pilot study. So duration of ventilation, delta SOFA score, ICU and hospital stay were comparable in two groups, but we need a more number of studies with a more number of patients involved in the adaptive support ventilation before we generalize the utility in all the ARDS patients. Again, some adjuvant therapies. We know that so for the ARDS to occur, there should be some sort of predisposing condition like sepsis, trauma, some chemical injury, ventilator associated lung injury, transfusion, or maybe some sort of graft rejection and all. So which leads to pathophysiology, which I already explained. So next, which leads to the final pathway of the ARDS, that is the final common pathway where epithelial barrier dysfunction, endothelial dysfunction and pulmonary edema is going to happen. Suppose if you are going to tackle in this pathway, okay, so suppose you modified the factor like give low tidal volume, restrict to transfusion strategy, VAP prevention bundle and all, we can bit control on this origin or the movement of this ARDS into the ultimate common pathway. So can we address with some adjuvant therapies like some proposed pharmacological intervention like aspirin, steroids, statins, some agents which act on renin and angiotensin blockade pathway, okay, adrenomedulin, curcumin. So all these things are happening as a newer adjuvant therapies in ARDS, but nothing has been concluded with a mortality benefit. We have to look forward for this page in terms of can we use adjuvant therapies in the management of ARDS with good mortality benefit. So in conclusion, this is the slide which shows where exactly we can apply which therapy, which intervention. If you see, low tidal volume is the one which we can apply all the level of ARDS, mild, moderate, severe ARDS. So low to moderate PEEP in patients whom we are going to have like mild to moderate ARDS. Higher PEEP we can consider in severe ARDS. ECMO, severe ARDS, refractory to all the regular way of managing the ARDS. So high flow nasal cannula, high flow oxygen means high frequency oscillatory ventilation, and definitely after these like oscillate and Oscar travel, Oscar trials, we have to wait for some more data on this HFOV. So neuromuscular blockade, so till we get some more data we can use in moderate to severe ARDS. Definitely prone ventilation showed a good outcome benefit in moderate to severe ARDS patients. So the famous Ketinoni told mechanical ventilation is a necessary evil in ARDS. If correctly performed, mechanical ventilation buys time to allow other therapies to take effect. If performed incorrectly, it may kill the patient. So thank you guys. I request all of you to subscribe my channel to get more and more evidence-based lectures in critical care medicine, anesthesia and emergency medicine. Thank you all.